Hello, welcome everyone. Thank you for joining us for our last session of the Oxygen Therapy and Critical Care series. Before we begin, just a couple of reminders. We will be using the chat function for question and answer. To access this, the button is at the bottom of your screen. So please send all questions and comments you have about the session through the chat, and feel free to introduce yourself as well. If you have any technological issues, send us a message through the chat and we'll do our very best to assist you. And the session is being recorded and your attendance is consent to being recorded, so thank you. So today we are on session 12. That is our last session of the series. And we have compiled all of the most frequently asked questions that we have received from participants on all of the topics. So Dr. Eugene and Dr. Jean-Paul will be presenting these today. And as you know, Dr. Eugene Tuyashim is from the Institute of Medical Education and Global Health, and Dr. Jean-Paul from the University of Rwanda. And so with that, I'll pass it over to Dr. Eugene.
Thank you very much, Alana, for a nice introduction. So I'm excited really to do our last session, but it's not the end of our program. So I hope that we'll be able to continue the program next year with new course, and we'll consider also adding the topic that are interesting to our participants. So for today, I will be with Jean-Paul, and we need active participation. So I don't know if Jean-Paul has something to say before we start.
Just saying hi to everyone, and very excited to the end of this session. So, and this will be a wonderful session. So I would invite our participants to be actively participating, interacting. This is a very, very, very important discussion to our daily practice. Thank you.
Okay, thank you, Jean-Paul. So let's start with the oxygen therapy. We can go down and start with a question. So what are the indications for oxygen therapy, and what are the purpose of oxygen therapy? So Alana, I don't think this is what I have on my computer. Can you go down so that I see the next slide? Keep going. I don't think this is what I have. If I can share my screen and show you what I have, I'm sorry for that. I apologize for the delay. Okay, sharing my screen here. I don't know if people have seen my screen, but this is the content I have. So, okay, let's use my content if people can see my screen.
So it is visible.
Okay.
Can see.
Yeah, so we start with the basics of oxygen therapy: indication, contraindication, some definitions, and signs and symptoms, and some causes of respiratory failure. So let's start with the first question here. So which of the following are indication for oxygen therapy? you can put your answer in the chat. So A, hypoxemia, B, hypoxia, C, hypocarbia, D, A and B, and E, no one of the above. Okay, is the question clear? Example, if you can check in the chat, I'm not accessing the chat, but I give them 20 seconds. It's an easy question.
It's no problem. I have the access on the chat. Emetogene said A and B. Anastas said D. Daniel A and B. I can see like three persons, they said A and B. All of them, they are meeting on D.
Okay, yeah, that's the correct answer. And the reason is hypercarbia, you have too much CO2. And the solution is not to give oxygen. The solution is to improve ventilation, where you need to think about the cause. And you may consider non-invasive ventilation, for example, or intubation, or you wake up the patient, or you reverse the cause. For example, if someone has like overdose of opioids, you may consider treating that. That's just one example. Or if someone has like COPD, you may consider giving bronchodilators, treating the cause. So oxygen therapy will not be the answer for hypercarbia. Okay, very good. Let's discuss the next question. Are there any contraindications to oxygen therapy? Are there complications related to oxygen therapy? So let's start with contraindications. If you can put two contraindications of oxygen therapy and two complications, that would be great. So this is a longer question, so we can have about 45 seconds. Jean-Paul, can you check in the chat and see the answers we have?
Yes, I'm waiting for them to put an answer, but no one yet reacted. Okay, they are saying complication, contraindication. Someone said contraindication when it's for a patient with SpO2 above 92. Another said upper airway obstruction. And the one highlighted about high fever and the COPD. Don't know if it's contraindication of oxygen therapy. I think you can, at the same time, you can, yes, you can add the complication as well.
Yes.
So that we'll discuss together. Any complication of oxygen therapy? I see Anastasia said retinopathies. There is another one who said retinopathies, Patrick. So far, we have retinopathy as contraindication in neonate. Yes. What else? Oxygen tolerance can be the complication of, okay, oxygen toxicity, it's a complication. What else? I'm sure we've discussed these.
Okay. Yeah, thank you very much, Arana. So we've got the presentation there. So the good thing is that we have all the content that people can look at after, but we can click on that to answer the question. But as you know, the common complications include absorption atelectasis, and the reason is you are replacing nitrogen, which is helping the alveoli to be open. So, and if you replace that with oxygen, you will cause atelectasis. So that's a big complication. So you may cause also airway injury, and also be careful of the patient with lung injury. A good example is patients who are taking chemotherapy with bleomycin, for example, who are always already having like fibrosis from the bleomycin. So if you see those type of patients, be careful of how much FiO2 you are giving. So in my experience, we use a very low FiO2, really below 35. Those are common complications. And in the pediatrics, remember that because of the eyes which are still in development, you can easily cause retinopathy, especially in the premature infant. That can lead to blindness. Those are some of the complications and considerations in using oxygen for patient. I don't know if Jean-Paul has something to add on that.
So, you've covered all the complications, the most common complication of oxygen toxicity. Here, the key message our friend have to know is that when you are putting a patient on oxygen, make sure that the patient really the patient need oxygen. Does the patient need to be stayed on oxygen for a long time? Remember, the exposure of oxygen to the patient for a long time may lead to complication. And give oxygen when is needed to the patient. Don't give oxygen routinely to the patient. That's the key message. I saw in contraindication, some of them, they've said patient refusal. Absolutely, in any procedure, in any therapy, in any treatment, the patient refusal is an absolute contraindication. But for oxygen, the patient can refuse oxygenotherapy because he can see or she can see the device that you are going to put on patient, and the patient may have fear and refuse. So it's up to you to explain the patient the benefit of that oxygen, the benefit of that oxygenotherapy. Don't let the patient suffer from hypoxia as you diagnose hypoxia or hypoxemia and you say that the patient is a candidate for oxygenotherapy and the patient refuses. It's up to you. Our job is to explain the benefit of that oxygenotherapy. Don't let the patient die, say the patient have refused. And remember, when a patient is hypoxemic, sometimes the patient may present some agitation and confusion. So it's up to you to judge and to help the patient. Don't rely on patient refusal. Just a matter of explaining the patient. So that was that. These are my comments.
Yeah, thank you, Jean-Paul. The other thing to keep in mind is the duration of oxygenotherapy and FiO2. Usually, we would recommend to use FiO2 below 60%. And also, we win oxygenotherapy as soon as possible. Usually, those complications are increased. The risk of complications are increased when you keep the patient with FiO2 above 60% for more than 24 hours. So the longer you wait, the more risk you cause. And also, in our current practice, most of us work in anesthesia. So don't give the FiO2 that the patient doesn't need. As what Jean-Paul said, usually for me, I would keep my patient with FiO2 around 50 or 40%. If there's no indication for high FiO2. So let's go to the next question, which is a basic but important question. So what is the difference between hypoxemia and hypoxia? So you have 30 seconds to put the answer in the chat. So while you are like responding the causes, think about the difference, think about the causes as well. What are the causes of hypoxemia? What are the causes of hypoxia? Um, we're still waiting for your answers.
Write up the difference between what is hypoxemia, what is hypoxia.
And give like two causes of each.
Okay, a Heterogene said, give an answer. Let's wait for others. Heterogene, can you give some example of hypoxemia and hypoxia? So while waiting, Heterogene said hypoxemia is the arterial pressure of oxygen in the blood, and the hypoxia is oxygen in the tissue. There is a missing key point.
Okay, people are very slow to respond. While we're clicking on the answer, so the way we think about that, as you know, is that hypoxia, um, yeah, it's lack of oxygen or decrease of oxygen in the tissue, and hypoxemia is lack of or decrease of oxygen in the blood. And the hypoxemia happens when you have low FiO2 or you have hypoventilation. We have a good like summary, which we have a good image which show those differences. So we think about shunt as well. We think about VQ mismatch. Um, and just keep in mind that in the case of shunt, uh, when you give oxygen, there's no good improvement. In the case, for example, of patient with pneumonia, atelectasis, pulmonary edema, or ARDS, yeah, we can see the answer there.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism. Lack of oxygen leads to cell death, tissue death, and organ dysfunction. The rate at which oxygen is removed from the blood and used by the cells and tissues is known as oxygen consumption. Oxygen in the blood can be detected a number of ways. The majority of oxygen is bound to hemoglobin. This is known as oxyhemoglobin. The saturation of hemoglobin can be detected directly using arterial blood gas analysis, or can be detected indirectly using pulse oximetry. When oxyhemoglobin is measured by arterial blood gas analysis, it is termed SaO2. When oxyhemoglobin is measured using pulse oximetry, it is termed SpO2. The small portion of oxygen that dissolves into the plasma creates an arterial oxygen tension or partial pressure and is known as PaO2. Pulse oximeters measure arterial oxygen saturation, termed SpO2. Hemoglobin bound to oxygen is termed oxyhemoglobin. Hemoglobin not bound to oxygen is termed deoxyhemoglobin. Pulse oximeters shine light through tissue beds, usually a finger, a toe, or an earlobe. Then they measure the amount of light that is absorbed. Oxyhemoglobin absorbs light at a different wavelength than does deoxyhemoglobin. The ratio of light absorbed by oxyhemoglobin versus the light absorbed by deoxyhemoglobin is displayed as a percentage by the pulse oximeter. Non-pulsatile venous blood and tissues also absorb light. However, these components are discarded by the pulse oximeter. The pulse oximeter only uses the values obtained from pulsatile arterial blood flow. Normal oxygen saturation by pulse oximetry is greater than 94%. However, when administering oxygen therapies, an SpO2 greater than 90% is usually acceptable. Pulse oximetry is non-invasive and painless for patients. Arterial blood gas analysis, termed ABG, directly measures arterial blood gases, oxygen, and carbon dioxide. Values obtained from ABGs include the pH, the partial pressure of oxygen, termed PaO2, arterial oxygen saturation, or SaO2, the partial pressure of carbon dioxide, termed PaCO2, bicarbonate, and base excess. Blood gas analysis requires a blood sample from the patient, which can be painful.
Before we move on, I would like to show to share my screen a little bit and show a summary of some causes. Okay. Yeah, I think everyone remember this picture, but the common causes of hypoxemia, as we discussed, include raw FiO2, um, and a good example is in the case of high altitude. Um, so hypoventilation, we have many causes, including CNS depression, muscle diseases, including Guillain-Barré syndrome. For CNS depression, we remember drugs like opioid, or in the case of trauma, and nerve injury, in the case of C-spine injury or phrenic nerve injury, and chest wall problem or trauma, including when there is a chest trauma or abnormality of the chest, including a kyphoscoliosis, for example. So those are some cause of hypoventilation. And there's diffusion problem, including pulmonary fibrosis, interstitial lung disease, emphysema. Those are some of the examples. And there's oxygen binding problems. A good example is carbon monoxide toxicity in the case of fire, for example. Um, and for cause of hypoxia, there's a good summary here on the right side. So it may be caused by all the causes of hypoxemia, or severe anemia, or ischemic problem, which can include shock or congestive heart failure, where the body is unable to pump blood to the tissues, as you can imagine, or arterial obstruction. Um, those are some examples, and issues with or at the level of the cell oxygenation. A good example is cyanide poisoning. Yeah. So I think that's a good summary. We can go back to the main slide. Thank you, Arana. So this is a simple question. So which of the following are non-clinical signs or symptoms of hypoxemia? So tachypnea, dyspnea, sternal retraction, accessory muscle use, loss of taste or smell, or altered mental status, or restlessness. Okay, nice. I see that most of the people got the right answer, which is C. This is straightforward. Let's continue to the next question. Yeah, so we will share some of the answers with more details for future use. So for this next question, what are the normal range of oxygen saturation? Yeah, that will be interesting to see what people think. You can put your answers in the chat. What is a normal oxygen saturation? And once you know that, what is the goal? Think about the goal of oxygen therapy. And as you may remember, there will be goals which may be different depending on the presentation of the patient. If you are pregnant, if you have COPD, or if you are in shock. Okay. MA is saying the normal oxygen saturation is 95 to 100%. Okay. Jean-Paul, are you happy to answer this question? I think people we have good response there, good response rate. Jean-Paul, we can't hear you, but I say that this is the answer.
Okay.
Yeah.
So I've been saying that in the chat box, most of them, they put the right answer starting from 94 to 100. As you can see here, we have some specific consideration. So the normal will be above 94, but there are some special consideration where we need to pay attention, and the goals is different. For example, if you can see from the last, we start with patient with COPD or patient with chronic asthma, the same with COPD. You will not tact the same normal SpO2 of 94. So these patients, they have been living with their normal, the saturation, their normal SpO2 is above 88. Actually, for them, they don't need much oxygen. So you need to pay attention for them. So the pregnant women, patients who are in shock, the reason is this patient, all of them, they are having increased oxygen consumption. The oxygen demand is high. That's why these patients, they can be on the same categories because of their increased oxygen consumption or demand. So the particular attention will be put with the patient with COPD and asthmatic patient. They have been having low oxygen saturation, which is quite normal for them. They don't need much oxygen saturation. So I don't know if Eugene has some comment to add on.
I don't have a big comment, but for COPD or shock, remember it's supportive care. So we need also to think about treating the cause. And in our context, most of the time, those patients will be sent to a referral hospital. We need to keep in mind how we can transfer them on time and how we can transfer them safely until they reach the teaching hospitals where there is more capabilities. So let's continue with the next question. Yeah, this is a straightforward question. So in which of the following situations should supplemental oxygen therapy be started? When SpO2 is below 92, when PaO2 is below 60, when a patient is in respiratory distress, and when a patient is in shock, all of the above. So just pick one. Yeah, I see most of the people got the right answer. each of these patients really they need oxygen therapy. They have hypoxemia and they need oxygen therapy. I think that's good. The other question is about how often do we do the monitoring for oxygen saturation, and how do we do titration of oxygen up or down? I think we can directly answer that question if Jean-Paul can answer how often we monitor the patient. So just we need to think about where is the patient? Is the patient in the normal ward? Is the patient in the ICU? Is the patient in the high dependent unit? Is the patient improving or is the patient deteriorating? So based on that, we can think about how often we monitor. We have some recommendations there, and Jean-Paul can help us to answer that.
Yes.
Reminder.
As you said, this depends on where the patient is located. As you can see, a patient in ICU or a patient in regular ward, maybe medical ward or surgical ward. So those who are in ICU or at emergency department, especially those who are in critical condition, they should be monitored their SpO2 no more than 15 minutes. And then each 5 to 10 to 15 minutes, they can recheck the SpO2. The patient who are in critical condition, this one should be monitored at regular basis. But those patients who are in medical ward, who are clinically stable, that they don't require to frequently checking their SpO2. Here they are saying even 80 hours, it's enough. Every 80 hours, on a patient who are stable in surgical ward or medical ward. So regarding to titration of oxygen, when do we have to decrease the flow or to increase the flow? When for increasing the flow, we saw the target, the normal oxygen saturation, the normal SpO2 target. Depending on a particular patient, we saw the category of the patient. If your patient, the SpO2 is still below of the target, then you can increase the flow. If it doesn't work, then you can change the device. So shortly we are going to revise the type of the device and how much FiO2 they are delivering. So it depends on the target. If the target is not reached, you can either increase the flow or you can change the device that you are using. If you are using a device which is giving low FiO2, you can go to the next. So it's the same with when you go down, when you decrease oxygen. When the target is reached, so there is no longer of having, for example, you were on maybe 80 liters per minute by facial mask, and then you see the patient is exceeding the target, then you can decrease the flow and see what will be the next oxygen saturation. If you are happy enough, then you decrease. The same time you are decreasing even the device. If you are having a device which was offering a high FiO2, then you can decrease, you can move on a device which is giving a low FiO2 until then you can wean off from oxygen. I think this is clear, and we've been discussing this so many times ago. Can move on the next. Right. In the next question.
Jean-Paul, the other thing I would like us to think about is a lack of ABG in most of our hospitals. So if we don't have ABG and the patient is saturating at 100%, most of the time we don't know the PaO2. And we have seen that oxygenotherapy may lead to toxicity. So I would recommend, if possible, to set the goal at around 99%, but because at least you know that the PaO2 is not very high. It's not more than like 100 and above. So that would be a good target. What do you think, Jean-Paul? Okay, I don't know if Jean-Paul got my comment, but it's something to think about.
Yes. Yes, I got your comment, and your comment is very, very, very important, especially in our setting where people they don't have to rely on saturation of 100%. As we saw, there are some conditions where maybe a patient might have 100%, instead is having hypoxia. Like a patient who got CO with hydrogen band, you may put SpO2 and it shows 100%, which is false. The real arterial oxygen saturation might be like 40 or 45. So if you have, like, as you said, the target of 99%, it's better.
Okay, so let's go to the next question. Which factors can interfere with pulse oximetry reading? How can the pulse oximetry be adjusted to ensure accuracy? So yeah, if you can put in the chat at least one or two factors which affect reading of pulse oximetry. Yeah, thank you, Arana. I think you helped them here. Yeah, I think light can interfere, but in my experience, this is not a big problem. But shivering, for sure, when there's a shivering, the patient is moving, so you may lose the signal. And when there is a low pulse or shock, and then the vasoconstriction, when the patient has cold hand, or you are giving, for example, vasopressors in ICU. Yeah, anything which can cause severe vasoconstriction, that can lead to poor reading. And as Jean-Paul has given an example of carbon monoxide, you can have a false high saturation reading. So just keep that in mind, especially in the patient who had a burn. Keep that in mind. So the other issue is people with nail polishing, when they have something on their nail. Sometimes you may consider asking them to move the nail polish so that you have one finger where you can put pulse oximeter. In other institutions, you may have ear probes. I don't think they are readily available in our context. Yeah, I think those are some of the common factors to think about. The other question is a simple question. How long should you provide oxygen therapy in a hypoxemic patient? And really, I think this is a straightforward question. So as long as you have to achieve your goal. So you need to set your goal and keep monitoring the patient. But the most common goal is SpO2 above 90. as you can see there. And for pregnant and shock patient, you can have higher goals. And as we discussed, COPD, people have chronic hypoxia, so they are tolerant to hypoxia, and you can have a lower goal of 88%. So we can continue to the next question about non-invasive oxygen therapy. And we start with a simple question as well. What are the different types of non-invasive oxygen therapy? How do they differ in terms of dosage, device needed? What are the advantages of each of them and these advantages? So I think this is a simple question as well. If we can click there, we can see a list of devices. As you remember, nasal prongs, which is commonly used, you can give about 5 liters. In my practice, usually we give between 1 and 6 liters per minute, and you can achieve FiO2 of around 40%. Nasopharyngeal catheter, I don't have experience using that, and it is not commonly available in our setting. So, but the face mask, I think it's commonly available, and you can go up to 10 liters, from 6 to 10, and you can achieve a high FiO2 around 60. And the other option is a mask with reservoir, where you can have about 10 to 15 liters, and you can achieve actually a high SpO2, FiO2 around 95. So, but for me, the recommendation I would give, if you are using a mask with reservoir in a district hospital, it's time to start thinking about the definitive treatment or the definitive plan. So is this patient going to improve, or this patient will need a transfer to a high level hospital? And how safely can we transfer this patient? And as Jean-Paul knows, when we were in our residence program, some hospitals will send patient and the oxygen finishes while they are on the way. That's why I think we discussed about how to calculate the amount of oxygen in each cylinder and the importance of pulse oximetry monitoring on while you are transferring patient. I don't know if Jean-Paul has anything to add on that, but my recommendation is if you are giving a mask, oxygen with a mask with a reservoir, really, it's time to think about a definitive treatment and disposition for this patient.
Yes, I do agree with you. So actually, in our setting, as you said, we typically have mostly these three: nasal plunge, simple facial mask, and a facial mask with reservoir. However, in COVID center, we have a high flow nasal cannula. So if we, as you said, the facial mask, the nasal plunge, this is the simplest one, which is giving a limited FiO2 no more than 40, and the flow also will be ranging 1 to 5. And remember that the flow above 5, above 6 of nasal plunge, you are causing discomfort to the patient. You are not helping a patient, and it will not increase your FiO2. So better, if you see the target is not being reached or achievable, better to think on the next one, which will be simple facial mask, where the FiO2 will go around 60, and the flow also, and then the facial mask with the reservoir, where you can go to the flow of 16. Simple mask, you can go up to 10, but with the reservoir, non-rebreather facial mask, you will go on 15. and the FiO2 will reach around 99% or 100. So if your patient is not doing better with the non-rebreather facial mask with reservoir, this is what Eugene was saying. It's the time to start thinking, can we transfer this patient in a higher setting? Or calling an anesthetist. This is the time to start thinking, can we intubate the patient? Can we intubate the patient and then will be transferred while intubated? Things like that.
Nice. Let's go to the next question. And I'm conscious about time. So some of these questions will just keep going because they are straightforward. So this one is an easy question. So which one of the following is in the correct order for least FiO2 to highest FiO2 delivered? So yeah, what is the correct answer starting from the device which is giving less oxygen to the device which is giving higher FiO2? Yeah, this is a straightforward question. Yeah, we agree with the one who, yeah, most of the people got the correct answer, which is A. Let's continue to the next question. Yeah, when is humidification needed for oxygen therapy and why? Yeah, I would like people just to try to answer that as quickly as possible. Why do we need humidification of oxygen and when? Let's wait about 20 seconds and then we can answer that. I don't see any answer. But remember, if you are giving raw flow, which means that you are giving less than 60 liters per minute, you don't really need humidification because the risk of like drying the secretions is very low with that, and also patient discomfort. But if you're giving more than 6 liters, you have to start considering really humidification. And in ICU, as Jean-Paul knows, there are many complications associated with not humidifying oxygen, where you have thick secretions, which may lead to like closing the airway and obstruction of the ETT and tracheal tubes, and for many complications from that. So with airway obstruction. So whenever you're giving high flow, start thinking about humidification, especially when you're above 60 liters. And or if you're bypassing the nose, but we don't usually use nasopharyngeal or oxygen device. So the second question is about humidification. Yes, we can sometimes consider reusing humidification bottles, but we need to be careful to minimize the risk of infection. Usually we don't need sterile water. you need just distilled water or boiled water, which is cold, as we have discussed before. Just be careful on how you do disinfection of these devices, and change water at a regular basis, usually every day. We have the details, and people can read more details about that. Um, the next question is about awake prone positioning, and we can click on that to see the answer. Yeah. Yeah, but the key point about prone positioning is that you are minimizing VQ mismatch or ventilation perfusion um, mismatch, usually because of the area of the back where the patient is lying. You have too much atelectasis, and then you change the area so that the lung, um, the other areas of the lungs can get more oxygen. Um, so you need to think about some considerations. Here, there is a guide you can use. I don't think we need to memorize this. We need just to be aware of common contraindications, uh, and some of obstetric contraindications to consider when the patient is in respiratory distress, for example, or impending respiratory failure with need of intubation, or hemodynamically unstable patient with low blood pressure, or agitation, and spinal thoracic injuries or recent abdominal surgeries that can't lie on the prone. And the relative contraindications, including facial injury, neurologic issues, morbid obesity. So just think about those. And before you do the procedure, as usual, we need to discuss about risk and benefit and get the consent from the patient. And lastly, think about when to go back to the supine position, especially if there's either improvement or there is no improvement. So you have this guide you can use to do that. And remember, you can consider prone positioning either in awake patient or non-intubated patient and in intubated patient. And we have seen before the way the technical aspect of doing prone positioning. I don't know if Jean-Paul has something to add on that, but this is a complex process, and usually before you start doing it, you need to discuss with people the experience.
Yes, as you said, uh, there is some advantage, pros and cons of the prone positioning. There are some advantage and some quite disadvantage, some indication and some contraindication. But with few experience with the COVID-19 patient that I've been caring, I've been attending, so in any situation where it's possible to prone the patient, it helped much, but it requires the staffing who will do the maneuvers of proning the patient. In the other setting, they have the bed where you can manipulate a bed, but in our setting, it requires the staff to prone the patient with a NTT risk of dislodgement or removal. So the key message here is to know that the prone positioning in the COVID patient, they have been shown to improve oxygenation. Yeah.
Okay, thank you very much. Let's continue with the next question. Yeah, about escalation of oxygenotherapy. I think we have touched about this briefly, but when should oxygen therapy be escalated? And the simple answer is that once you are not achieving the goals with low flow, then your option is to increase the flow and increase FiO2. And that will go with the devices which can allow you to achieve your goal. And they ask about devices which can give high flow oxygen. And as you have seen, there is a high flow of nasal cannula, and also with mechanical ventilation, you can give high flow as well. So how long should it take for SpO2 to improve? And when should the patient be intubated or pressed on a mechanical ventilation? So we can click on that and see, but it's very variable depending on the cause of hypoxia. We can click on the video.
Before discussing airway management and modes of mechanical ventilation, it is important to review the indications for intubation and mechanical ventilatory support. The indications for intubation and mechanical ventilation can be divided into 4 broad categories: hypoxic respiratory failure, hypercarbic respiratory failure, airway protection, and a non-sustainable work of breathing. Hypoxemia is defined as a partial pressure of arterial oxygen less than 60 millimeters of mercury, or an SpO2 or oxygen saturation less than 94% by pulse oximetry. Although an SpO2 less than 94% defines hypoxemia, oxygen therapies and mechanical ventilation may not be indicated until more severe hypoxemia occurs or respiratory failure becomes evident. Causes of hypoxemia include decreased inhaled oxygen, alveolar hypoventilation, and VQ mismatch. VQ mismatch includes both dead space and shunt. Is common in several pathologic clinical states, including pneumonia, ARDS, and pulmonary emboli. Hypercarbia is defined as a partial pressure of arterial carbon dioxide greater than 45 millimeters of mercury, as measured on arterial blood gas analysis. Hypercarbia is common in COPD, emphysema, and hypoventilation. Common causes of hypoventilation include medications, altered mental status, head injury, and severe metabolic derangements such as hypoglycemia or myxedema coma. Patients often need to be intubated and mechanically ventilated for airway protection. Patients with altered mental status may have associated hypoventilation and inability to clear secretions. Further, obtunded patients in the supine position have muscle relaxation of the tongue and soft tissues of the posterior oropharynx, which fall backwards, obstructing airflow. Examples where airway protection may be needed include stroke, head injury, sedation, overmedication, and anesthesia. Patients with a non-sustainable work of breathing may need to be intubated and mechanically ventilated. Patients struggling to oxygenate, ventilate, balance a metabolic acidosis, or overcome airway obstruction should be considered for mechanical ventilation. Struggling patients demonstrate any or all of the following characteristics: a high minute ventilation with an increased number of breaths per minute, an inability to speak in full sentences, and obvious accessory muscle use. Pathologic examples include status asthmaticus and severe metabolic acidosis.
Yeah, that's a good summary of when to escalate oxygen therapy and consider intubation. So there are some safety concerns about when you are using oxygen. And people can just think about a few things. So first, you need to have good identification of the oxygen devices you are using or source of oxygen. If you are having e-cylinders, it's easy to put a wrong identification and give hypoxic mixture, which will be really concerning and leading to like complication in patient. So imagine if you are giving, thinking you are giving oxygen and then you are giving CO2, for example. So that's why we need to make sure we have a good identification in place. Um, or we need to think about, is there any mixture in our oxygen? Is there any oil which is mixed with this oxygen, for example? Uh, so the other issue to think about is if there is any leakage of the oxygen. So you are losing oxygen, wasting the supply. That's another consideration. So we need to make sure um, the, the oxygen is well closed and with proper fitting regulators and flow meters. That's important. And remember, there is a risk of explosion. So that's why we need to make sure there is no source of fire in close proximity with our source of oxygen, like cylinders. So there's risk of explosion. As you know, oxygen is very highly flammable. So those are some of the considerations to think about for safety concern. Um, I think that's very easy to understand. So good identification, don't waste oxygen, be careful about risk of explosion and being flammable. So the next question is about the supply of oxygen available. Um, so for us, I think most of our hospitals we use cylinders, but also we have concentrators. Oxygen plants may be available in some of the hospitals, and I don't think we have liquid oxygen. Um, so just keep that in mind. Know the key message for us is to know the source of oxygen you have and the capacity, so that during the weekends or night or when they have increased in patient in the hospital admissions, we don't uh, like get shortage of oxygen. I think that's the key message for us. We need to understand how much oxygen we have in our institutions. I don't know if Jean-Paul has something to add on that.
Yeah, actually, there is nothing else to add. As you mentioned, these are the common one we have as the source of oxygen. Maybe if our participants they have any question, probably they can ask and then we can discuss.
Yeah, and we have slides we'll share with those common source of oxygen and the advantage and the disadvantages. Um, yeah, the other simple question here is about rebreathing carbon dioxide with non-invasive oxygen device and face mask. I think this is the question most of the patients would ask, like if they are using face mask, are they going to breathe CO2 or being hypoxic? Um, but as you know, there is no evidence for that. So as long as you have a well-fitting mask, uh, you can use it without any risk for CO2 intoxication, because CO2 particles, they are very small. They can easily go through the mask. So they are smaller than even the viruses we are protecting against. So that's the simple answer we can give to patients, that it is safe to use a facial mask. Okay. Let's see the next question about like single-use equipment or reusing equipment. Um, yeah, uh, so I think about, I know in our context we use most of our equipment, but the key message for us is to make sure we understand how the equipment are being washed and disinfected, and make sure that we minimize cross infections, especially if you know that the patient, for example, has TB. Let's not like use um, their mask for the patient which is close to them, or patient who is confirmed with pneumonia and a resistant uh, virus or resistant bacteria. Um, let's be careful of cross contamination. That's a good example of a solution you can use for the contamination of some of the devices, um, and using 0.1% sodium hypochlorite solution. So I'm not sure if this is available in most of our stores in Kigali or other region, but just the take-home message: be familiar of the disinfectant we use in your hospital, and make sure it is always available and the device you are using has been disinfected before using it to another patient. Uh, this will bring us to our last question, which is about ARDS. Um, and this was a big topic, so I will be happy if I can see the answers you give in the chat. So what is the definition of ARDS? In full, as you know, is acute respiratory distress syndrome, but what are the main criteria for defining ARDS? So usually we have four criteria, so it's up to you guys to answer that. You have 45 seconds. People are very quiet. I don't know if it's a difficult question or not. Um, yeah, I don't know if people remember the Berlin criteria for ARDS, and this is a common problem, and it would be great if people in like district hospitals or provincial hospitals could diagnose this patient early and send them to the teaching hospital early to improve outcomes. because the more severe the ARDS is, the poor the outcomes are. Okay, I would, probably Jean-Paul can help us to answer that. There are 4 criteria for acute respiratory distress syndrome, as you can see there. Jean-Paul, we can't hear you.
Thank you, Eugene. So, I said people that have been quiet in answering this, maybe with ARDS patients. However, there are some criteria. I can comment on the answer of Mutagoma, who said that there is desaturation, dyspnea, increased work of breathing. Yeah, yes, it might happen, but we have criteria when we say this patient is having RDS or is probable having RDS. There are some risk. If I can say, there are some criteria. If a patient had the first one is the onset. Since when this patient is presenting this, you say the saturation, the senior increase the work of breathing, since when? If during 7 weeks, I mean 7 days, just 1 week, if a patient had now insult, that means maybe a patient has a chest contusion, anything like an insult of his lungs or her lungs within 1 week, the insult, there should be an insult. That's one. Within 7 days or in 1 week, if there is a
I don't know, we lost Jean-Paul, but he was saying you have like respiratory insult, well, within 1 week. You may have chest contusion, for example. You may have a pneumonia. So once you have that for within 1 week, and on X-ray or chest CT scan, you have bilateral infiltrate. So with pulmonary edema, which is not fully explained by a heart problem or heart failure. So that is a second criteria. And also, you have a low PaO2 to FiO2 ratio, which is below 200. And lastly, you may think about severe once you have a PaO2 to FiO2 ratio actually below 100. So, but in summary, you need to have a respiratory insult, which may be infection, but it may be trauma. And after that, that has to be shown on X-ray or a CT scan. And also the respiratory failure should not be explained by a cardiac failure. So once you have that, and on top of those, you have PaO2 to FiO2 ratio below 200. But what this means in reality is that you are needing a high FiO2 in order to maintain a high saturation. As you know, PaO2, you get this number from arterial blood gas, and for most of our hospitals, we don't have easy accessibility to ABG. So we're going to look for the next question, how we can go about that. So because once you don't have PaO2, you can use a regular saturation, but you have higher numbers of PaO2 to FiO2 ratio. We can click here. what we can do if we don't have ABG. Yeah, so I think this is very clear. So the team with Professor Theogene Twagirumugabe and colleagues, they have validated a Kigali modification of the Berlin criteria. So as you can see, you have one respiratory insult within 1 week. That has not been changed. But what has been changed is PaO2 to FiO2 ratio. Rather than being 300, you can have SpO2. For example, if the patient is saturating at 100, and then the FiO2 is 1, which 100%, then you have the ratio below 315. So you may start considering that the patient may be having ARDS. But imagine if you have only a FiO2 of 20%, which is 1/5. So if you have 100 over 1/5, so the ratio is around 500. So it's bigger than 300. So you don't have ARDS. So in other words, if you are using a raw FiO2, or the patient is in room air and is saturating well, or it's just on nasal prongs saturating well, you don't really have risk of ARDS. But remember what we said about when you are giving a high flow oxygen. If you are giving oxygen with non-rebreather mask, which is a FiO2 around 95, and the saturation is still low, you are most likely to have a risk of ARDS. And what that means for us is that the patient may need ventilation and need to be transferred for high level of care where they have ICU capabilities. So the other criteria is you don't have PEEP in that. And for opacities, you may use ultrasound or chest X-ray because in the low-income settings, the CT scans are not easily available. And the origin of cardiac failure, there was no change about that. As long as it is not fully explained by cardiac or heart failure or fluid overload. So this brings us really to the end of the common asked questions. I know it's a lot of information, but we'll share the PDF summary of all the answers. Yeah, this is a good quote, which can help us to conclude our sessions for 2021. So yeah, Anne Frank said, how wonderful it is that nobody need wait a single moment before starting to improve the world. So yeah, you can keep doing a good work, and I wish you all Merry Christmas and Happy New Year 2022. So before we finish, I will let Arana explain our process to give you the CPD credit and certificate, and we'll keep you posted about our next sessions, starting probably in January 2022. Once again, I thank you very much for your attendance and your kind attention, and I hope we will keep working on these teachings, and it will help a lot of people. So thank you very much.
Thank you, Dr. Eugene. As this is our last session of the series, we did want to ensure that everyone knows how to access all of the materials for ongoing reference. And so I'm about to share my screen to show you how to do that. So as you know, this course was created by Dr. Anna Maria Crawford from Stanford university in the US. And she used this platform called the Learning Resource Center to host all of the materials. So I'll share the link for that in a moment, but I want to walk you through how to access that. So in the link that I share, you'll see a screen, Global Anesthesia Critical Care Learning Resource Center. You do have to register for an account to access the materials. Registering is free, and it'll give you access to this course and others that are in development. So we do encourage you to do that. So to register, you would click sign in. And you can log in using your Google account or email, or separately. And once you do create it, you can log in on this page, and that will take you to the course page. You would click on the Oxygen series, but as you can see, there are a number of courses that you can explore. Once you click on the Oxygen series, you'll see under Module 2, Oxygen Therapy and Critical Care, a case-based discussion series. This is where you would go to visit all of the modules that Dr. Eugene has presented in the past year. So for example, today's session is under Part 4, Frequently Asked Questions, but there are 12, along with all of the recordings, supplementary materials, decision-making tools, exercises. It goes on and on. So we encourage you to check that out. If you click on Module 4, for example, for today, at the top of each module is a small paperclip icon. And when you click on that, you'll see a PDF that is associated with each module. And when you click on the PDF, it gives you the answers and some of the, explanations for some of the theories that we discussed during our monthly session. So all to say, we hope that you make use of this. It will always be freely accessible, and is accessible on your phone or your computer. And so it can be a big help since these sessions are now over. We also would encourage you to use the WhatsApp group. So if you're on a WhatsApp group and you have questions about the content, or you come across a clinical challenge and would like to get some advice on how to deal with it, the WhatsApp group is a great place to sort of keep those conversations going. Once again, we'd like to thank all of our participants for calling into these sessions and sharing your answers in the chat and asking such great questions. Visit the Learning Resource Center for slides, recordings, and more. And we'll also be working in the next few weeks on certificates for CPD points. So if you've attended 75% of the sessions, you are eligible for a CPD points, and we will be distributing that either later this month or in the early new year. These will be distributed by email, so please keep an eye out for those. And as we conclude, I would also like to say thank you again to Dr. Eugene and all of his panelists, including Dr. Jean-Paul, for being such excellent teachers and dedicating their time to this program. I'd like to thank Project ECHO for funding this program and making all of this possible. And Dr. Anna Maria Crawford from Stanford Anesthesia for creating the curriculum for the program. So if you have any questions, email echo@assistantinternational.org. And otherwise, happy holidays, and we are wishing you all a peaceful and restful last few weeks of the year.
Yeah, thank you very much, everyone. Have a nice weekend. So bye.